In hopefully 15 minutes, I'm going to cover an estimation of the prevalence of what is variably called non-clozapine, clozapine resistant or clozapine refractory schizophrenia. So we'll talk about approximately how many people we're talking about. I'm going to guide you through assessment or a thinking process when encountering the appearance of clozapine non-response. We're going to discuss the nature of the evidence base for clozapine non-response treatments. Spoiler alert, it's what you might call spotty. But the problem won't go away just because we don't have the highest quality of evidence. And then we'll talk briefly about some of the therapeutic interventions that are out there that seem to have some tradition of being used and that seem to have a bit of sense behind them. So first, just to be clear, clozapine, or to remind folks, clozapine is approved by the FDA for the treatment of treatment-resistant schizophrenia. Clozapine also has another FDA approval for the reduction of suicidality in schizophrenia and schizoaffective disorder. Parenthetically, it's the only drug in the entire pharmacopoeia which is recognized to reduce suicidality. But back to this. So treatment-resistant schizophrenia is defined typically as not responding to adequately dosed trials of at least 2 other antipsychotic drugs. And when we're talking about clozapine non-response, in this talk, we're going to talk about people that have been on clozapine, that have been able to tolerate it without side effect or adverse effect burden, and who are willing to take it, and who, despite all that, are not getting the desired response. There are situations in which a person has had some response to clozapine, but they can't stand taking it due to various adverse effects, or never tried clozapine or unwilling to try, or the providers are reluctant to prescribe. Those probably have other considerations that aren't particularly relevant to this particular talk, so we can set those aside for perhaps another discussion. So what portion of people might have this non-response to clozapine phenomenon? And it's actually, the number is kind of small. These figures that you see here are all fairly well established in the literature, that approximately 30% of schizophrenias are so-called treatment-resistant. Thus, 70% of schizophrenias are responsive. Of the treatment-resistant group, between 40 to 60% are going to be finding clozapine both tolerable and helpful. So you take 30% of 60% response rate of that 30% of non-responders, added to the responders to usual drugs, and you get some people might consider a surprisingly large number of 88% of people with schizophrenia should enjoy a good therapeutic response or potentially outright remission to either the first-line antipsychotic drugs or to clozapine, leaving 12% plus or minus a few of schizophrenias being in the category of clozapine non-responsive. So relatively speaking is a small number, but the patients that do well don't see you very often in your office or your hospital, and the patients that struggle see you more. So in the clinician's practice, it's going to be probably more than 12% of schizophrenia-affected people with this clozapine non-response problem. So when you encounter such an individual, here are things to think about as a first approach. First, if the person's illness has not gotten better with standard antipsychotic drugs, which to rephrase that, have not gotten better with D2 receptor antagonists, it's probably not what I call a dopamine psychosis, and therefore it opens up the possibility that there are other causes, like inflammatory psychosis may be at play, glutamate psychosis may be present, or any of these other occult medical illnesses. So when you encounter the clozapine non-responder, it's a very good plan to collect all the records and see what tests have been done to rule out occult medical illness. So if a person has cerebral cysticercosis, or one of these rare cases of an autoimmune disease which has not been detected, they might get a little bit better with some clozapine augmentation, but they'll get a lot better if you give them steroids, for example. So it's by the time you get to be a clozapine non-responder, you have entered the territory of the zebras. In other words, of the rare patient with the rare causes. So the odds that you find a zebra go up when you look at this very rarefied group of patients. I think most clinicians will just automatically scan the medication list for drugs that are obviously psychotogenic, like steroids, for example, or stimulants. But in these situations, it's important to consider what I learned from beginning. Anybody can have any side effect from any medication. So there are cases of frank psychosis that are resulting from lamotrigine or from topiramate or from benztropine. So any of these drugs that are generally innocuous in standard practice, you should consider the possibility that you may be looking at, in this particular patient, one of those rare cases of an ACE inhibitor causing psychosis. And I'm not just pulling these out of the hat. There are actually case reports of psychosis associated with all these drugs that I mentioned in the examples. So consider that, and in general, just eliminate as many drugs as you possibly can, looking for a remission of psychosis. Consider the possibility that there's occult substance use, that they're either using drugs which would otherwise be detected in drug screens when you're not screening for drugs. There are also a whole bunch of drugs which never show up in drug screens. Ketamine is a fairly popular drug of abuse, and it's not screened for routinely in urine drug screens or blood toxicology. So keep in mind that might be a possibility. And finally, consider the environment of the patient, the degree of environmental or social stressors or supports, because it may be the fact that they are able to respond to the treatment if there were appropriate modifications to the environment. So do all those things to try to look for reasons why the person is not getting better before doing the next thing. The next thing to consider to do is first wait longer. Clozapine, keep in mind that the time frame to recovery from clozapine can be much, much longer than it is for standard antipsychotic drugs. So if the person has been on clozapine for 3 months and they're not better, I would still continue on that medication for at least 3 more months. Monitoring along the way symptom severity to see if there's a signal for symptom reduction as you continue the dosing. It's also an ideal strategy to get a blood test the next time they do their CBC, and add a clozapine and norclozapine blood level. You might get back, depending upon the laboratory, you might get a range of clozapine concentrations which are posited to be therapeutic, but that's just a very rough guide. There's actually not a hard and fast therapeutic clozapine level. There are, however, levels of clozapine which are known to be associated with increased risk for seizures or other toxicities, but primarily seizures. So although a drug level is not going to tell you if you're in the therapeutic zone, it will at least let you know how far away you are from a maximum. And there are some ultra rapid metabolizers of clozapine on the planet. I had one young man who was on 1,200 milligrams of clozapine, and he had minimal clozapine levels in his blood. In that particular case, I gave him 25 milligrams of suboxamine to inhibit his clozapine metabolism, and he had a very rapid rise. And in that case, he didn't get much better, unfortunately. So he was truly clozapine resistant. But nonetheless, had I not checked his serum clozapine level, I would have not tolerated the idea of having him on 1,000 milligrams at the time. But for him, it was still a small dose. So now we're moving on to, so those are some considerations. These considerations are basically continued clozapine with some modifications. We're going to pivot into if those things have been done and it's truly, if there are no other occult medical causes or psychotogenic drugs and the clozapine has been adequately dosed for a long enough time and you're still left with clozapine non-response, we're going to talk about that. Talking about that, though, leads to this commentary upon the quality of the evidence base in the not responding to clozapine population. This is a very small number of individuals. consider that schizophrenia affects about 1% of the population, and treatment, the clozapine non-responsive subset of schizophrenia represents about 10% of those, then you're looking at 1 in 1,000 individuals in the population with clozapine non-responsive schizophrenia. Difficult to find such people. If you can find them, they're both likely to not be homogeneous. They have had a whole bunch of different pharmacological strategies up to the point where they're potentially going to be enrolled. They are more likely than not to have a variety of hospitalizations or other significant environmental challenges. So doing research is hard. And if you can find them in a group, they're often in situations where they are deemed protected class. In other words, impaired to the point where their ability to provide consent is impaired, or in situations like state hospitals or other institutions where they're considered vulnerable to undue influence. So in a way of protecting them in one facet of ethics, they're kind of almost systematically excluded from research, which is unfortunate, because if ever there was a group of people needing more research, it would be this category of individual. So things to consider then: don't just stop clozapine altogether. Even if there's no signal that has been helpful, if the person has been on the medicine for more than a few months, if you rapidly reduce the dose, you will have all manner of withdrawal problems. You can have a rebound psychosis, you can have a worsening of psychosis, and you can have a serotonin withdrawal syndrome, and numerous reports of suicide completions after abrupt discontinuation of clozapine. So taper the dose of that. And similarly, the same goes as well for standard antipsychotic drugs. If they've been on them for any period of time, unless you're going to cover the same receptors with a new drug, drugs should be tapered probably on a multi-week to multi-month time frame rather than a at once or over a few days time frame. Another problem, in addition to rebound psychosis and suicidality, is that you will possibly unmask tardive dyskinesia, which had been masked by the higher doses of antipsychotic drugs. So slow tapers are preferred in this situation. Probably the strategy which is most often used, at least it has some rationale, is to add a high-potency D2 receptor blocker drug. Popular drugs that would fit that are at the bottom: risperidone, haloperidol, aripiprazole. Haloperidone would cariprazine. Medications with high affinity for D2 receptor would be in that category. The rationale for doing so is that clozapine has very low affinity for the D2 receptor. So the theory is that by adding a high affinity D2 ligand to a drug with low affinity of that receptor, you sort of complete the spectrum of receptor activations. It's a nice theory, which, according to some case reports or some case series or some single investigator studies, has some evidence for benefit. So it's kind of easier to do because you don't have to change the clozapine. You can just add another medication, and so it's a common strategy. Neuromodulation, I was initially going to title this site electrotherapy because ECT stands for electroconvulsive therapy. These days we use succinylcholine to paralyze the muscles, so there's really no convulsion involved. So I think I'm going to make a bid now for calling it electrotherapy. Sounds nicer and is more accurate. Nonetheless, I call neuromodulation because I want to include some other modalities. ECT has a very long history, certainly of misuse in the asylum era. But actually, in terms of the treatment-resistant or the clozapine-resistant patient, it has a reasonably good track record of support, and it's been a long-standing practice. The literature sort of converges on a finding that if there is some aspect of affective disturbance to the person with schizophrenia, it may have a stronger likelihood for success. So it's an option, and certainly then it allows the clinician to taper off medicines like the standard antipsychotic drugs that haven't worked, and people can, if they're not cleared from psychosis, they can at least be cleared from some of the side effect burdens of ineffective drugs. In the more modern area, transcranial magnetic stimulation has some evidence for support in clozapine-resistant schizophrenia, and transcranial direct current stimulation does many of the same things to the brain as TMS does, but it does so at greatly reduced cost. And there are promising reports of resolution of psychosis in clozapine non-responsive schizophrenia. Again, reports; those are case reports, case series. We're in this whole area. We're talking about practices which, unfortunately, lack the kind of data sets that we would like to see. Speaking though of data sets, this group published in the Australia and New Zealand Psychiatric Journal a meta-analysis where they tried to find every randomized controlled trial that they could for the clozapine-resistant patient, and they came up with this estimation of effect sizes. The table shows aripiprazole, fluoxetine, valproic acid, and memantine. Take a look at the effect size of 2 for valproic acid. Skeptical part of me wants to think that's probably an outlier somehow. It's a massively large effect size. Fluoxetine at 0.7 is still pretty big, and aripiprazole at 0.5 is on par with the effect size of most antipsychotic drugs for garden variety schizophrenia. And notably, memantine, a glutamate receptor modulator, has a significant effect in this meta-analysis, but it was for the negative symptoms. So something to keep in mind for consideration of in your practice. I will, since this is a small group, I will send you the PDF of the papers that I'm showing here. And this paper has, just in the abstract, it has some sentences that I think are applicable to every pharmacotherapy in psychiatry, but they do specifically mention that the evidence base is small, so it's difficult to say with the kind of certainty we're used to, use this treatment first, use this treatment next. First thing, as we said, look for reasons for clozapine non-response and address those. Any strategy that you use should be based upon some rationale that you can write down in a chart note and explain to a patient. And then, as you write your chart note and explain to your patient, you need to say, what we're most concerned about right now is, and then define the symptom or symptoms of primary importance. In hospital settings, it's often aggression. In outpatient settings, it can be severe hallucinations or suicidality or whatever it would be for the individual. But we have to get very granular and very specific when we start to use these off-label treatments. So declare why you're choosing the treatment, what your symptoms are that you're trying to address, and how you're going to look for their resolution, as well as an endpoint and a time frame. So, for example, I'm going to try adding aripiprazole to the clozapine treatment of this individual. I expect that the aripiprazole is going to have a significant reduction of hallucinations to the point that this individual will be able to leave the house, engage in therapy or whatever. Let's say leave the house and engage in outpatient psychotherapy. I expect, based upon my knowledge of aripiprazole therapeutic time courses, that I should be able to meet this target in 4 months of treatment. So today is October 1st, 2nd. So by February, if this person is not having a 50% reduction in the frequency and severity of hallucinations and able to go to his outpatient therapy, I will stop the aripiprazole, and then I will probably at that point not try a D2 receptor modulator drug. I would probably go to a glutamate modulating drug or fluoxetine for, again, the choice depends upon clinical situation, but know what you're trying to treat, track it, have a target and a time frame, and if it hasn't been met, then stop the treatment. In doing so, you will not expose your patients to treatments that are unnecessary, and you will not clutter the therapeutic field with polypharmacy, which makes it very confusing. So to finally summarize, this is a very important problem, despite the fact that it's a relatively small population. It's vital to know what you're looking to improve and ways to measure it, and choosing whatever strategy you go with in addressing the clozapine non-responsive patient. And I've said this before in this forum, and I'll say it again. The real world is full of examples of cases which are not well described in textbooks. In fact, everything that we think we know about schizophrenia is derived from randomized clinical trials involving patients that don't use drugs, that have only schizophrenia and have a moderate level of symptoms and are able to give informed consent. So this is a relatively narrow subgroup of patients, which doesn't represent a whole lot of real world situations. And so being in communities like this, where we can have 5 or 20 individuals with years of experience, we are able to pool our collective knowledge and learn from each other about what works, or what might be good or better practices to address these important clinical problems. So with that, I will stop this presentation.